Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Jolyn Taylor from the Department of Gynecologic Oncology at MD Anderson Cancer Center here in Houston, Texas. And the topic of this discussion is going to be the article published in our journal titled Glycemic Control to Improve Postoperative Outcomes in Patients with Type 2 Diabetes mellitus, Results of the Sugar Surgical Universal Euglycemic Attainment During Recovery Initiative. So, Jolyn, such a pleasure to have you on the podcast. Thank you so much for accepting our invitation. And of course, obviously, thank you for submitting your article to our journal, and congratulations to you and the co-authors.
Thank you so much. Thank you so much for the invitation to do this, to discuss glycemic control around the perioperative period. It's something that I'm very passionate about and falls within the realm of quality improvement. And I'm excited to discuss what we found.
Yeah, so thank you again. I mean, obviously, this is a topic that is dear to our hearts, and certainly a journey that I took part in when I was at Anderson with you as well. So congratulations, obviously, for continuing to explore these important questions. So I wanted to start by discussing how important is glycemic control in the perioperative period.
So data suggests that avoiding severe hyper or hypoglycemia in the perioperative period decreases the risk of multiple major adverse events, including things like surgical site infection, urinary tract infections, and pneumonia.
So with that, for this particular study, what were your main objectives?
So the objectives of our initiative, the Sugar Initiative, which is a quality improvement initiative to standardize preoperative screening, preoperative hyperglycemic referral algorithms, and intraoperative and postoperative hyperglycemic management, was really to assess how much did this intervention impact our glycemic control. And then as a secondary objective to assess, how did that glycemic control translate to better avoidance of infectious outcomes?
Fantastic. Um, Looking at now at this particular study, looking at the main objectives and the methodology, can you tell us a little bit about how you put together this study, the inclusion criteria for the study?
Absolutely. So in this study, we assessed the impact that the Sugar Initiative had on improving the perioperative glycemic control using a goal glucose of less than or 100 milligrams per deciliter among patients with type 2 diabetes undergoing an open gynecologic surgery. We also assessed the impact of our initiative on the rate of surgical site infections, pneumonia, and urinary tract infections among the same patient population. So we started this in terms of our methodology by getting approval from our quality improvement assessment board, and then forming a multidisciplinary team to standardize how we did preoperative screening, what our referral algorithms were, and then how we managed intraoperative and postoperative hyperglycemia. All patients with type 2 diabetes undergoing non-emergent gynecologic surgery by laparotomy were included for our analysis. Patients with type 1 diabetes or patients undergoing emergency surgery and those who were being cared for on another surgical service were excluded because we felt like that was a different patient population. Minimally invasive surgery is overall a lower risk surgery in terms of postoperative complications and has a shorter time to collect data related to glycemia. So those cases were also excluded for this analysis. We also captured all of our data prospectively, which I think is a strength of our assessment as well.
So now the study encompassed a total of 103 baseline patients, 167 intervention patients with diabetes. What were the main results?
So overall, we found that our patient characteristics were pretty well balanced between the two groups. And then when we look at our compliance outcomes, because when we think about quality improvement, I always think it's important to also describe the compliance when we're thinking about the overall results, because then that gives more confidence that what we're seeing has to do with the initiative itself. So we saw really good compliance with obtaining hemoglobin A1Cs prior to surgery, up to 95% after we started the intervention. And we also diagnosed 11% of patients, or 18, with newly identified type 2 diabetes. And so with that kind of understanding of how the cohorts compared in terms of demographics and compliance, in terms of the results and outcomes, the percentage of postoperative glucose values meeting the goal of being at less than or equal to 180 milligrams per deciliter increased from a baseline of 77% to 86% in the intervention cohort. The compliance remained really high throughout all the different aspects of care, whether assessing glucose preoperatively, intraoperatively, or postoperatively, and we had good compliance with our interventions overall. And then when we compared the infectious outcomes, though, we did not see a significant difference between the rates of surgical site infection, pneumonia, or urinary tract infection between the two groups. And when we looked at these to see if they also varied by glycemic control within the two groups, we didn't find a correlate between the rate of glycemic control and the infectious outcomes, or if we just looked at it even between baseline and post-intervention.
Great. So lots of questions actually about those results. And as you know, we typically go to those questions from our fellows in the journal. So we'll start with this one, Clara Santia from Argentina. What hemoglobin A1C cutoff value did you use to diagnose those patients with type 2 diabetes, specifically the 18 patients who were newly diagnosed?
Excellent. So we aligned with the definition provided by the American Diabetes Association of using a cutoff value of 6.5%.
Okay. This next one comes from Julia Gellison, University of Wisconsin in Madison. And she's asking, how did you choose your intraoperative glucose monitoring frequency and postoperative insulin regimen?
This was part of our multidisciplinary process and something I really enjoyed, especially because I learned from some of our colleagues in anesthesiology and endocrinology and how they think about our patients with diabetes going to surgery. The intraoperative monitoring frequency was in alignment with recommended best practices by anesthesia quality metrics, as well as expert opinion from our collaborators. The postoperative regimen was modeled after the recommendations from the American Diabetes Association and the Society for Endocrinology, which recommends a basal bolus approach. So what that means is that you have basal insulin provided, weight-based, long-acting, and then you add additional coverage for meals and additional coverage based on how hyperglycemic a patient is going into the surgery. Then our endocrinology collaborators tailored the insulin regimens to not only our formulary, understanding what medications we had available, but also to be very conservative, understanding that our patients would not resume a normal diet right away, and what hold parameters would be needed to ensure the safety of our patients and avoid episodes of severe hypoglycemia because of being in this perioperative time period.
Excellent. Next question comes from Christian Braun, Lucerne Cantonal Hospital. And he's asking, were there any intraoperative risk factors, such as duration of surgery, that were identified that correlated with postoperative blood glucose levels exceeding 180?
So we did not identify any risk factors because our sample size really limited that type of assessment. I think that's an excellent question and really gets to some of the other kind of questions even I had when I looked at the data of where do we go next and what do we do to answer why we didn't see a change in our infectious outcomes? Kind of what more do we need to understand about patients with diabetes undergoing the stressors of surgery, especially within the framework of oncologic surgery?
Yeah. Manuel Montesinos Albert from the Hospital Universitario and Polytechnic in La Fe, Valencia. He's asking, given that infectious complication rates did not significantly decrease despite improved glycemic control, what potential factors or limitations might have contributed to this outcome? So certainly I knew this question would pop up, particularly obviously focusing on surgical site infections.
Oh, absolutely. Because we see other publications that suggest glycemic control has correlated strongly with avoidance of surgical site infections. Um, we understand that diabetes itself is a risk factor for these infectious complications, and more evidence is arising that the mechanism is likely multifactorial, including inflammatory effects from hyperglycemia, and that can lead to impaired innate and adaptive immune responses. There's also a weakened barrier system where there might be increase in bacterial translocation or contamination. And then finally, the higher levels of oxidative stress and inflammation associated with hyperinsulinemia, as well as hyperglycemia. And so given all of those factors, we don't know which one might be driving different microenvironment changes. And while avoiding severe hyperglycemia is believed to undo and improve some of those factors, it's still to be shown exactly how much does avoidance of hyperglycemia alone drive it? How long do you need that control? And is there an impact where below a certain threshold, you're seeing more incremental improvement? And that might be why we didn't see significant changes or a clear direction.
Yeah. So as a follow-up to that, Matteo Marchetti in University of Padua, he's asking, despite better glycemic control in the intervention group, there was no significant reduction in infectious complications. Do you think this could suggest a ceiling effect for glycemic control in reducing surgical site infections, or might other unmeasured factors be playing a role?
Right. And unfortunately, we don't have the sufficient sample size to answer that accurately with our study. But there may be a ceiling effect that if you achieve a certain level of glycemic control, then other risk factors become the driver for an infection. We don't have the data to answer that, but I think one of the things that I thought was so valuable about this study is that we were able to show what wasn't sufficient to make a difference and really raise questions about how do we want to understand this disease going forward? What can we do to kind of add to the body of literature around this so that when we are understanding and trying to craft quality improvement initiatives to keep our patients safe, you know, how do we take this information and think where do we need to put more resources to have the biggest possible benefit?
Okay. Kara Fisher from University Hospital in Heidelberg, she's asking, the authors found no differences in the rate of postoperative complications between the baseline and the intervention cohort. Which patients do they think would benefit most from an intensified blood sugar management as described in their study? How would they define inclusion criteria for a potential intervention trial in the future?
Oh, absolutely. So our patient population was overall relatively well controlled compared to other published studies. And that may have blunted the observed impact on infectious complications. We also identified fewer undiagnosed patients with diabetes, and those we did identify had better overall control than population level data suggested expected. For example, most of the newly diagnosed patients with diabetes, their hemoglobin A1Cs were between 6.5 and 7.5. These weren't patients who had a hemoglobin A1C of over 10 that were wildly out of control or had poor access to healthcare system in the first place. So, I think understanding that, it means that when you're thinking about which patients may benefit from that, I wonder if those patients who have poorer control at baseline, and we might see a bigger delta in the change from baseline to intervention might benefit more. A strength of our design was that we were able to capture very granular data to be able to assess the impact of this intervention and prove it was safe and understand how our intervention impacted the glycemic control at each stage of the perioperative journey. We had no cases of DKA, which is a serious event, or severe hypoglycemia. I think I would propose a larger analysis of patients undergoing laparotomy across multiple surgical specialties to try to increase the sample size and better understand how glycemic control levels can correlate better with avoidance of infectious complications. Because it's also very unclear how some of the glycemic control initiatives might correlate with oncologic outcomes. So another area I'd love to see is, can we see any difference if we are maintaining improved glycemic control broader and longer throughout their oncologic journey? Are we seeing any differences in outcomes?
So now, Christian Brown back from Lucerne, he's asking, what was the average time between the pre-op consultation and surgery? And did the sugar initiative, particularly the focus on glycemic optimization and endocrinology referrals, lead to an extension of this timeline? In other words, did it delay surgery?
Right. And within the realm of oncology, that would be a major concern if we saw a tension between trying to optimize glycemic control and getting to a needed surgical intervention. Part of our multidisciplinary approach meant that our endocrinologists were very supportive, and they agreed to same day or next day consults for patients who had poorly controlled diabetes and needed intensive intervention. So our average time for the consultation was easily within a week. I don't have the time from our usual preoperative consultation and surgery, but from quality assurance reviews of the process, we did not see that there was any delay in getting to the operating room that was due to endocrinology consultation. And so it would be our usual practice.
Okay, back to Julia Gellison from Madison, Wisconsin. Is there any data assessing if pre-op or intraoperative glucose values impact perioperative outcomes, including infection, or have most prior studies, such as those cited in the paper, focus only on post-op glucose control? Did you do any analysis to see if there were different outcomes between patients on insulin preoperatively and those on oral or non-insulin anti-hyperglycemic agents?
Yeah, so to address the first part of the question, we assess for any correlation with glycemic control across every time period, and we did not find a correlation. It is very important to acknowledge, though, that the data were limited and we had smaller sample sizes as we looked at infectious outcomes. And I caution that that might be more hypothesis generating than conclusive. When you have data looking at post-operative outcomes, you obviously have a larger amount of data to correlate it with. And so some other studies have tried to find what part of the operative episode might have such important control for glycemic kind of metrics. And a lot of times you'll see it suggested either the hemoglobin A1C, which can tell you how controlled they are going in, though doesn't account for any intervention that improves that, or the postoperative period where you really see just the tight control within the hospital. And as we get better and better at discharging patients from the hospital, that time frame is expected to shrink as well. So our study, though not powered to, it did not see a correlate between the two. And then similarly, when we're looking at differences between those on insulin preoperatively and those on oral and non-insulin, we didn't see a difference in those. It really depended on kind of, were our patients well controlled? And for our patient population, I think what's important to differentiate between other studies or other hospital settings might be is that those who were on insulin, they probably had a poor control, also had good access to healthcare, and were utilizing their insulin regularly. And so their glycemic control was actually pretty well proved. But we didn't see a difference between those on insulin and those on oral anti-hyperglycemic medications, though I caution that I don't think we were powered to really assess that thoroughly.
Yeah. This next question, how could the findings of the Sugar Initiative influence guidelines for preoperative screening and management of hyperglycemia in high-risk populations?
No, so the sugar protocol was shown to be safe and effective at avoiding hyperglycemia. I would encourage others to consider this as a blueprint to glycemic management for your institution. We had no episodes of DKA, which is a severe adverse event, and we had no episodes of severe hypoglycemia either. So this approach and this general methodology was shown to be safe. And I also found that it really allowed for a holistic approach and preoperative, intraoperative, and postoperatively because it gave patients an opportunity to be optimized going into surgery. So I had higher confidence that afterwards they also would stay within a safer glycemic range and not risk severe shifts in their glucose control because we'd already optimized them before surgery.
Yeah. And I should add for our international listeners, DKA is diabetic ketoacidosis. We in the United States tend to use lots of abbreviations. So now, Jolene, for this next question, Elise Yates from our own Houston Methodist here in Houston. While minimally invasive surgery was not evaluated in this study, would you anticipate similar results if it had been included?
I would anticipate seeing similar results, especially given we didn't see a difference in infectious outcomes. I wouldn't expect to see a difference in infectious outcomes for a minimally invasive population, especially as they already have low rates to begin with. In terms of glycemic control, we very well may see some improvement in glycemic control, but with fewer data points to assess overall if we're thinking about their hospitalization and typically their lengths of surgery as well.
Okay. This next question again is from Clara Santia in Argentina. Considering that the body undergoes significant stress during surgery, leading to an accelerated metabolism and potentially elevated glucose levels, what value do you see in measuring postoperative glucose in patients who were not previously diagnosed with diabetes before surgery?
This is a great question with minimal data to guide an answer. Our institution has a policy that if a patient is on steroids, obese, glucose is monitored preoperatively and postoperatively during surgery if it's elevated during the intraoperative period. No formal analysis has been completed yet on this population, but it is a point of discussion and something that we're considering understanding a little bit better. And I think it gets back to the question of what is unique to diabetes, and that process that we believe has to do with oxidative stress, and we talked about earlier, and how much is related to pure hyperglycemia.
Okay. These next two questions come from Stephanie Gill at the University of Toronto. And the first one is, in future studies, do you think it would be beneficial to stratify or statistically control for BMI in this population?
Yes, I do believe BMI would be good to stratify for, as similar to what we've talked about, we want to try to tease out how much of complications we see has to do with factors that are correlated to diabetes, like high BMI, and how much has to do with the glycemic amount itself, because that can really help target what our interventions are. And when we're counseling our patients, we can give better estimates in terms of what our level of concern is.
Her second question is, for institutions that may not have the resources as you have to implement all aspects of this intervention, what do you think is the most important part, the pre, the intra, or the post-op component to implement, and why?
So I think those two critical parts. For me, I believe improving the glycemic control leading up to surgery has the most impact overall because you can decrease preoperative inflammation and feel more confident that when the patient leaves the hospital, they're still going to have adequate control because you've addressed what they're doing at home in terms of diabetic management. And then while in the hospital, post-op control is really important to avoid those severe outcomes like the diabetic ketoacidosis, to make sure that that never occurs for one of our post-operative patients. And so that's a safety net. But in terms of overall, how I think we can probably best serve our patients, if you can only pick one, I think if you can improve their glycemic control by being able to optimize them going into surgery, that should have the biggest impact that carries throughout the perioperative time.
Great. And Jolene, Elise Yates wants to know what challenges, if any, were encountered during the implementation of the sugar initiative.
So I think quality improvement initiatives always have challenges. One of the many reasons I love doing them, because we have to ensure stakeholder buy-in. And what that means is that we need to hear from the many different facets of care that impact our patients. And in order to do that, it takes understanding their perspective. What are their concerns? We also had to ensure that everyone felt like this would be a safe initiative. And there were questions in terms of why are we doing a basal bolus type of order for our postoperative patients and giving them insulin? How do we know it's safe? And so I think that that's a very valuable process, and there were some concerns raised. But when we were able to show that we were dedicated to following these patients closely, feeding back that information to our teams, the ones who had the most concerns then became the champions in order to say, you heard our concerns, we're validated in raising those, and we made adjustments too. We made adjustments to some of our, we've expanded the sugar initiative to other departments within surgery. And so we were able to account for unique settings that they had that we didn't, such as tube feeds. So giving enteral feeding and trying to understand what do we need to do to keep our patients safe. So the challenges were being able to hear those concerns and get engagement from it rather than just mandating a change and kind of having disengagement from our teams.
Yes. Excellent, excellent points for leadership qualities. So thank you. Now, I just have two more questions for you. This one comes from Thomas Bartle, Medical University of Vienna, and he's asking, given the association between obesity and poor glycemic control, and considering the high obesity prevalence in the United States, about 40%, compared to lower rates in Europe, less than 20%, in China, about 5%, do the authors believe the sugar initiative is applicable and equally effective across different regions of the world?
So while data suggests there's overlap, certainly between infectious risk for diabetes and obesity, there may be benefit for patients in optimizing glycemic control regardless of BMI. This is why I think it will be really important to try to tease out those differences as we study this, and additional data are needed. But the sugar initiative safely avoids the diabetic ketoacidosis or the severe hypoglycemia and does improve overall glycemic control for our patients. And from the available literature, we do believe that having improved glycemic control can help with our postoperative care. Now, which patients might benefit the most, I think is still up for debate and an area that we need to understand better. But in terms of the management of diabetes, I think the sugar initiative can still improve avoidance of severe hyperglycemia and overall improvement. Now, your patient population is where that'll help guide how much of a delta, how much improvement do you expect to see?
So now, Jolene, is the last question. This one from Kira Fisher. She's asking, has a study led to changes in clinical practice in your institution? Do they routinely plan patients for the intensified pre, peri, and postoperative blood sugar management? And if so, which patients?
We do. So we continue to use the sugar initiative in our department. And as I shared, it's expanded throughout our entire division of surgery. And so our institution has really become more accustomed to talking about diabetes and understanding what are things that we can do to decrease the possible complications of severe hyper or hypoglycemia. We also are applying for a special designation in our institution that recognizes optimal management of our patients with the diabetes. And the sugar initiatives have been the critical portion that speaks to how perioperative management is done within the broader institutional approach. And I would say, I think it's only going to become increasingly critical as we have more patients who are on different types of diabetic medications, and also as they're exposed from different types of therapeutics, and we're seeing differences in how they're managing their glycemic control overall.
Well, Jolene, I want to thank you very, very much for this opportunity to have this discussion. Always learn so much from listening to you and having these conversations. I really also want to congratulate you, commend you for the amount of effort, time that you have devoted throughout the years to really make this a reality at MD Anderson. And I'm so glad to hear now that it's actually moving on to other services. And I think certainly, again, we can learn from this study to take this initiative to our own institutions. So congratulations to you and everyone there who's working on this sugar initiative. Thank you.
Wonderful. Thank you so much for the opportunity to talk with you.